Good morning, everyone. My name is Akhilesh Sujan. I'm team leader for Humanitarian Emergency and Disaster Management. I welcome you all for this fourth webinar in the Don't Panic webinar series organized by the Charles Darwin University's Northern Institute and Humanitarian Emergency and Disaster Management Program. Today's webinar is focusing on the topic Crisis and Complacency, why the cycle must stop with COVID-19. This talk will be delivered by my colleague, Ms. Miranda Booth. Miranda has many qualifications under her belt, and she's currently coordinating Bachelor of Humanitarian Aid and Assistance program and also pursuing PhD in the similar areas at the Charles Darwin University. You can read her more detailed bio when the announcement was made for the seminar, and we can also share the link later. So, in the interest of time, I would request Miranda to start her seminar. Thank you.
Okay, thank you, Akhilesh. And thank you, everybody, for joining me this morning for our Crisis and Complacency seminar. So before we begin, I'd like to acknowledge the traditional owners of the land and that we're meeting and pay my respects to the elders, both past and present. So today we're going to be introducing the concept of disaster risk reduction, and we'll be applying it to understand investment in the reduction of health risks. We'll review hazard and risk reduction strategies, consider investment trends using 2 case studies, consider explanations for varied levels of investment, and we'll be reflecting on the way forward. So today we're going to be focusing on 2 public health threats, which are epidemics and pandemics. So epidemics are infectious disease outbreaks in a community or region, and pandemics are epidemics that occur worldwide or across a very wide area and affect a very large number of people. Now, this figure on the right here shows us one key trend from the last 50 years, which is that the number of infectious disease outbreaks has increased steadily. And this is because these hazards have been released accidentally or deliberately, such as anthrax, but they can also be understood as newly emerging, such as the H1N1 virus, or re-emerging, such as cholera. And although these hazards have been referred to as naturally emerging or re-emerging, I would suggest that a range of social factors, such as poorly managed interaction between society and the environment, makes the community more vulnerable to these kinds of hazards. And it's also important to note that new infectious disease outbreaks are becoming more frequent. In fact, they've increased 4-fold over the last century. Between 2011 and 2017, the World Health Organization tracked 1,307 epidemic events, which is an average of around 186 events per year. COVID-19 shows us that no one is immune to the risks of these hazards, but they can be prepared for and their adverse impacts can be mitigated. So disaster risk reduction is a concept that we can apply to prevent new and reduce existing risks while managing residual risk. And the goal is to prevent and reduce hazard exposure and vulnerability and increase preparedness for response and recovery, and thus strengthen our resilience. How can we use this framework to understand preparedness for public health emergencies? Well, the United Nations defines preparedness for public health risks as having the capacity to prevent, detect, contain, and respond to the spread of disease. Now, the 2003 SARS epidemic emphasized that there was an urgent need for an international legal framework for infectious disease control. In 2005, the International Health Regulations, which is a binding agreement among member states, were updated, and they obliged member states to maintain core public health capacities related to the detection, reporting, and effective response to public health risks. So now I'm going to ask you in the chat box to estimate, if you can, how much you think preparedness would cost per capita per year. You can estimate a number between 0 and 10. Three, 4, 10. 0.01. Okay, there's some good suggestions there. Well, the fact is that estimates to adequately invest in preparedness vary. So in 2015, the National Academies of Sciences, Engineering and Medicine estimated that it would cost $4.5 billion per year. And this is on average $1 Australian per capita per year, or it's about the equivalent of one McDonald's soft serve with a flake if you're treating yourself. But in 2019, the World Health Organization called for a yearly per capita of investment of between $1.50 and $3 a person. And that's the cost of a chocolate bar on special at Woolworths, or about 1.5 kilos of bananas. But it's important to note that preparedness is complex. Because the definition of a pandemic is primarily geographic, it groups together multiple hazards, and each type of event will require its own preparedness and response strategy. And we also need to acknowledge that preparedness is complicated. At a minimum, countries need a solid legal and regulatory foundation, a well-trained and equipped public health workforce, strong detection and response systems, and good coordination between different actors. But is there a strong case for preparedness? Well, failing to adequately invest in basic health security yields a high response cost. And we can see this with the Ebola epidemic in West Africa between 2014 and 2016, which cost the global economy over $53 billion, which is the equivalent of more than $1.8 million per case. The crisis cost the 3 affected countries of Guinea, Liberia, and Sierra Leone almost $3 billion in combined GDP. And before this outbreak, these economies were growing rapidly. We should acknowledge that economic costs are amplified by fear, which causes us to overreact in some cases and alter our behavior to reduce the risk of exposure. So during the Ebola crisis, over 30% of state parties disregarded World Health Organization recommendations not to impose severe restrictions. In Sierra Leone, the disruption to travel, among other factors, caused hotel occupancy to plunge from 70% to 13% in 1 year. However, it's generally agreed that preparedness yields a high return on investment. In 2017, the World Bank estimated a return of investment of about $18 per $1 invested. And we can understand these returns using the idea of the triple dividend of resilience. So investing in risk reduction and preparedness saves lives and losses when a hazard event occurs. It stimulates economic activity and it generates co-benefits. For example, if we invest in diagnostic capacities, we can also use them in the routine care of patients. But how does the cost of risk reduction compare to the risk of an infectious disease outbreak? Well, we can look to malaria as an example. Between 1930 and 2000, there were 75 resurgent events, and 91% of these events were linked to a reduced investment in malarial control programs. And data shows us that various factors are increasing the risk of an infectious disease outbreak. Globalization is one of these factors. For example, between 2015 and 2018, the Center for Disease Control and Prevention, recorded around 2,500 travel-related cases of the Zika virus compared to around 200 locally transmitted cases. Climate change is another factor. For example, there was a historic heat wave in the Arctic Circle that thawed dead reindeer infected with the anthrax bacteria, and this bacteria infected a nearby community. And while current global health infrastructure is currently built on national governments and their health systems, their ability to manage health risks is being affected by conflict. The average duration of civil wars is now about 20 years. And when states cannot govern public health systems, sanitation systems, and immunization programs are interrupted. Diseases such as wild polio can re-emerge in fragile states such as Afghanistan. And as a result of this widening global disorder, health has been acknowledged as a cross-cutting issue in several global policy frameworks that are at the center of the 2030 Agenda for Sustainable Development. For example, the Sendai framework emphasizes building capacity to cope with risk and address multiple hazards, including biological hazards such as epidemics or pandemics. And Sustainable Development Goal 3 is devoted to good health and well-being, with an emphasis on risk reduction and the management of global health risks. The Intergovernmental Panel on Climate Change Assessment Report also acknowledged that climate change is exacerbating public health risks. One key trend in disaster risk management is that investment is not progressing at the rate that we need it to curb losses when a disaster event happens. So in 2010, the World Bank identified that only 1% of bilateral and multilateral disaster management funds are allocated to reducing risk. How does this trend apply when we consider risk reduction in public health? Well, in 2019, scholars analysed international funding for global health functions from major international donors such as the United States and the United Kingdom to low and middle income recipients. And global functions were split into three categories: global public goods for health, such as the development of technical guidelines, the management of cross-border externalities, such as outbreak preparedness and response, and fostering global health leadership through activities such as health advocacy. Now, these scholars found that in absolute terms, funding for global functions grew from $5.9 billion in 2013 to $7.3 billion in 2015, before funding declined to $7 billion in 2017. And they attributed this spike in funding to the Ebola crisis in West Africa. And they used this evidence to argue that international donors are willing to help contain infectious disease outbreaks. However, donors tend to behave reactively to outbreaks rather than sustaining investment in risk reduction and preparedness to manage the threat of public health risks. And they concluded that international funders are prone to cycles of panic and neglect. In other words, panic during the Ebola crisis saw funding for preparedness efforts rise, followed by a decline in funding during the neglect phase once the immediate health risks had passed. So this is the study that's at the level of global donors. But we can also see the same phenomenon by examining funding from the United States, which is the single largest global donor to health security efforts, which are defined as those efforts that help countries prepare and address pandemic and epidemic diseases. And as we can see from this chart, spikes in United States supplemental funding for global health security have been driven by specific disease events. So over the course of the decade, funding for global health security generally ranged between $400 million and $500 million per year. However, it spiked to $1.3 billion in 2015, reflecting the emergency funding provided in response to the Ebola outbreak, and spiked again in 2016 in response to the Zika virus. So we can also see this trend in global health security as a percentage of US global health efforts overall. The average share of 5% spiked to 12% in response to the Ebola crisis before falling sharply to 5% again in 2016. And this is despite the supplementary funding that was provided to address the Zika outbreak in that same year. And we can also see this trend by examining how funding to agencies delivering US global health security efforts have fluctuated. And there are three main agencies that implement programs in partner countries: the USAID, the CDC, and the Department of Defense. And we're going to examine USAID only for our example. So funding for this agency was less than $75 million for most years, but fluctuations are strongly connected to outbreak events. For example, the agency received $201 million in connection to the H1N1 influenza outbreak, $385 million in response to Ebola, and $218 million in connection to the Zika virus. Now, these fluctuations in funding are significant. For example, decreased funding to the CDC saw their presence decline from approximately 49 countries to around 10. This is significant because we know that effective response to a hazard event, whether it's a disaster or a pandemic or both, requires that there's a strong capacity on the ground to execute operations. Now, the cost to re-establish or reinforce a presence, rebuild relationships, and meet the combination of urgent needs could be overwhelming. So significant disease outbreaks such as the Ebola crisis demonstrated that national governments and development partners had not effectively financed preparedness and response capacities. For example, in 2014, only 64 countries reported meeting core capacities, while 48 failed to even respond to the World Health Organization request for information. Significant policy attention has therefore focused on expanding and sustaining investment to build preparedness and health capacity so that countries are better able to prevent, detect, and rapidly respond to threats. And we have seen significant efforts at the international level, from international financial institutions such as the World Health Organization and the World Bank, and also at the regional level, such as those led by the Africa Center for Disease Control and Prevention, and also the Indo-Pacific Health Security Initiative. But studies from 2019 also indicate that progress has been very uneven. So in early 2019, researchers developed an epidemic preparedness index that showed that countries with lower preparedness levels were geographically concentrated in West and Central Africa, Southwest Asia, and areas within Southeast Asia. Now, these geographies were also widely considered to be at a heightened risk of disease emergence. So the study illustrated that there is a potentially dangerous mismatch between infectious disease emergence and outbreak risk on one hand, and the local capacity to detect and mitigate these risks. In September 2019, the Global Preparedness Monitoring Board, which is an independent body co-convened by the World Bank and World Health Organization, warned that there was a significant risk that a lethal pandemic would occur and wipe out nearly 5% of global GDP, and that the world was not prepared for this to happen. The next month, the Global Health Security Index was released. Now, this index was the first comprehensive measure of the global health security capabilities of 195 countries. And it found that no country is fully prepared for epidemics or pandemics. For example, the average score was 40 out of 100, and more than 73% of the world population lives in countries that score below 50. Most countries don't have health system capacities to respond to health emergencies, and more than 55% face significant political and security risks that could undermine their ability to manage infectious disease outbreaks. Even countries that are better prepared have gaps to address. For example, in early 2009, Mexico began to report cases of what we now know was H1N1. The United States surveillance web did not pick it up until mid-April, around 4 months later. The vaccine was slow to develop, and it's claimed to have prevented no more than 500 deaths. This is the fewest of any flu season in the surrounding 10-year period. And of course, in December 2019, we saw the emergence of COVID-19. In March this year, scholars analysed global health security capacities in the context of COVID-19. And they found that countries varied widely in terms of their capacity to prevent, detect, and respond to novel infections, such as COVID-19. For example, just over half of 182 countries were operationally ready to respond. And complacency to risk is serious because it has economic, political, and social consequences that can reverse progress on the Sustainable Development Goals. So let's look at Goal 3, which is good health and well-being. During the Ebola crisis, inadequate access to routine care led to an additional 10,600 deaths, and childhood immunization rates fell by 30%. Today, aid funding from other projects, such as the Global Fund for HIV, TB, and Malaria, has been rediverted to the COVID-19 response, undermining global health. And infectious disease outbreaks can also have longer-term political impacts that affect state capacity. So Goal 16, peace, justice, and strong institutions, is affected by infectious disease outbreaks. In the early 1990s and 2000s, for example, extremely high HIV and AIDS prevalence rates among African militaries led to increased absenteeism, decreased military capacity, and decreased readiness. And the weakening of security forces can increase the risk of civil war and other forms of conflict. And these social impacts are also apparent. In 1994, an outbreak of plague in a community in India caused only a small number of reported cases. However, fear led approximately 20% of the city's population, including a disproportionate number of healthcare workers, to flee the community. So not only can this type of migration spread an infectious disease, but migrants face elevated health risks that arise from the poor conditions such as sanitation and poor nutrition and other stresses. So one persistent challenge that COVID-19 revealed is that there is a lack of political will at all levels. Although national leaders are likely to respond to crisis when fear and panic grow strong enough, most countries don't devote consistent energy to keep disease outbreaks from escalating. And prospect theory is useful to understand why this is the case. So prospect theory suggests that investors value gains and losses differently. In simple terms, we are most likely to invest in opportunities that are low risk and produce a high return on our investment. So how do we see this play out when we're considering investment in risk reduction? Well, governments will choose the options that offer the most perceived gains. In developing countries, where resources are scarce and pressing needs exist, reduction and preparedness programs will need to compete with other essential activities like education or infrastructure, which generate immediate and visible returns with much less risk. And the certainty effect is also important. This is to say that people would rather accept a small but certain reward over the mere possibility of a larger gain. Investment in risk reduction and preparedness only produces benefit once a disaster event occurs, and predicting events such as infectious disease outbreaks can be inherently difficult. So decision makers will tend to view investment in risk reduction as an uncertain gamble that will only yield a return on investment in the event of a disaster. And governance is also important to understand why we have varied levels of investment in risk reduction and preparedness. So disaster risk governance refers to the way that society cooperates to prevent new risks from emerging and manage and reduce existing risks. The countries that perform best in disaster risk reduction are those countries that have good disaster risk governance. This means that they have strong regulatory systems, meaning that governments can make good policies, a strong legal system, meaning that people are likely to follow the rules, and the courts can fairly enforce these rules. And it also means that groups in society who are involved in the policy-making process. It also means that groups in society are involved in the policy-making process. And this idea of participation reflects the vulnerability paradigm, where it's often the most poor and the most vulnerable members of society that are affected by hazards. And their perspectives should be accounted for when we're identifying risks and designing appropriate response measures. This type of social participation also mobilizes government commitments. So having good disaster risk governance creates an environment where political will is mobilized, and there are systems in place that facilitate broad participation and partnership. Countries that don't perform well in disaster risk reduction are those with weak disaster risk governance, meaning that they don't have these essential elements of governance that they need to mobilize government commitment and facilitate participation. Moreover, corruption is one key outcome of poor governance. Not only does corruption discourage investment in disaster risk reduction, it also affects capital inflows, meaning that donor states will typically allocate less aid to recipient states if they're more corrupt, and it also discourages foreign direct investment going into the country. So successive health crises have highlighted to us that when it comes to global health security, we can only be as strong as our weakest link. However, the data demonstrates that if we have the political will to invest in risk reduction, we can effectively respond to disease outbreaks. Now, typically, investment in the reduction of health risks has followed a cycle of crisis and complacency, meaning that investment in reduction activities spikes when there's an infectious disease outbreak, and funding diminishes once the immediate health risks have passed. Now, success in health preparedness rests upon countries' abilities to identify gaps, develop plans, and finance them. However, there's weak compliance with the international health regulations. In 2018, only 1/3 of countries met the minimum standards for core capacities, and not a single national action plan for health security has been fully financed. This indicates that there are persistent obstacles and challenges that are undermining investment in risk reduction, and today we looked at 2 of those. In poorer countries, competition over competing resources and poor elements of governance undermines national investment in risk reduction. Corruption has also been shown to negatively affect inflows of official development assistance from less corrupt donors to more corrupt recipients, which reinforces the cycle of neglect. Even countries that perform better have gaps to address. All countries are currently underinvesting in risk reduction in favor of more certain, immediate, and low-risk gains. We're also seeing a broader failure failure of leadership to mobilize political commitment in risk reduction. So G7 countries have made 4 separate commitments to support 76 countries to build their core capacities. However, follow-through is lacking. And in contrast to previous crises like Ebola, where United States leadership was praised as fundamental to the response, the United States has returned to isolationism, leaving a leadership gap when we're looking at the global response to COVID-19. And as in any crisis, we're now seeing repeated warnings that we need to prepare for the next pandemic. The World Health Organization warned that we're dangerously underprepared for the next pandemic, and people are warning that more pandemics will come. I would suggest that for us to be prepared for the next pandemic, we need to build consensus on the threat that health risks pose to sustainable development, and achieve cooperation in long-term sustainable funding for both risk reduction and risk governance in all countries. Thank you for listening.
Thank you very much, Miranda. You must be tired. Take a break. Let's see, the participants in the room would like to ask any question or make any comment. I welcome everyone. Mona, you started your day pretty early, it seems. If you're in New Delhi, it's probably 6:30 in the morning over there. You get your first chance to ask questions.
Thanks, Akhilesh. In fact, I think this is one of the best I have, heard in a long time. This presentation and the work that you guys have put together. So first of all, I'd like to congratulate the team. I'm going to ask a very, it's a very innocent but maybe a stupid question. How do you gauge preparedness? Because there was, in the initial part of the presentation, a lot of focus on preparing well, and even I think the parting note was, we're not prepared for the next one yet. What are those 20% things that would give us those 80% results that we want?
Great, that's a fantastic.
Over. Thanks.
Yeah, sorry to interrupt you. Was that your question? So how do we measure preparedness, and what's the 80% to give us our 20% investment? Yeah, okay. So there are a variety of ways that we can measure preparedness or come up with an understanding of how ready countries are to detect and respond to infectious disease outbreaks. So one of them is led by the World Health Organizations, which is the International Health Regulations Core Capacities Monitoring Framework and the monitoring tool. But one of the big limitations of these was that there's no enforcement mechanism. So countries have no incentives to actually follow through with their obligations. And so because of this, in 2014, the United States led and established a multilateral initiative called the Global Health Security Agenda. And this directs funding into helping countries achieve their core capacities, and they also expanded this to include other technical areas. One of the key limitations of this global health security agenda was that reporting was still based on countries' own self-assessment, and so there was no willingness, again, for countries to even report on what they had achieved. So in 2016, we had the development of the Joint External Evaluation, which means that countries would respond against these indicators of their core health capacities. And we also had the National Action Plan for Health Security. So once countries identified what their risks were, then they could look at financing through domestic resources. And that's one way we could get the 80%, 20% ratio, which I can't think of the words to explain now, but I know what you mean. So it will be specific for each country and based on the gaps identified in that National Action Plan for Health Security. But it's also important to recognize that it's also important to recognize that these frameworks and policy initiatives that have been created are not free from criticism. And so some scholars in 2019 developed an epidemic preparedness index that aimed to overcome some of the limitations of those frameworks. Does that answer your question, Mona?
Yes, thanks very much.
Fantastic. Thank you.
Very much indeed.
Can I ask a question?
I'm a bit nervous now.
No, it's Achilles as a moderator.
You don't need my permission, Professor Lassa. You can go ahead.
Right, fantastic presentation, Miranda. I think I would like to continue on the questions that Mona asked before, and you provide the response that the countries are more open to, provide self-assessment rather than, creating another assessments like IPCC modeling, where scientists are the ones that do the assessment rather than, health officials provided their own reports, formats or templates that is provided by the WHO. But everywhere you go into different sectors like disaster management or disaster risk reduction by UNHCR, or if you go to different UN mechanisms like biodiversity or even climate change, I think apart from Montreal Protocol, most of the international multilateral arrangements are not that, they're based on kind of voluntary reporting system rather than, and if you push the member states like Trump too much to the corner, the best thing that they could do is stop the funding. So in the end, you won't have a good global system because they feel like this is the game that they will be losing, including losing face. So I think it's okay for me. I mean, from the realist point of view, it's okay for them to do the voluntary reporting systems as long as they can do that. And over time, we can actually push them to increase the quality based on evidence rather than based on self-serving kind of, kind of reporting. That precisely happens in the UNHCR system. Most countries have been trying to provide reports. Countries like Indonesia have been trying to be a good boy in the global stage. They provide the report like every 2 years. While top countries by countries that have good reporting, good health systems like Singapore, Australia, we only provide like once every 10 years. So that's also a tricky point. That's voluntary, but sometimes people feel like they don't have to report on a regular basis. So, I mean, if you put yourself into WHO and you are doubting about your next salary, whether the donors will keep their promise and transfer their money on a regular basis, I think it's pretty hard to do so. And also one last comment on the criticism on China, that they have been trying to influence WHO for now. But isn't that the same thing like, like the US have been doing for tens of years, trying to influence, but at the same time trying to de-influence it by not giving the money. So it's pretty tricky when we are imagining global multilateral systems that could push for, more stricter arrangement. Do you have any suggestion on how to solve this problem?
If
you put yourself as a WHO staff, how would you respond to that?
So on your first point about reporting arrangements and the lack of consistency, there's always opportunity for these frameworks to be improved. And like you said, countries can report once every 10 years. There is no obligation for them to test their systems each year, for example. There's no incentives for them to really do anything at all when it comes to it. There's no enforcement mechanism. One thing that I think that we could do, in addition to trying to make countries' compliance with these frameworks more consistent in terms of the need for annual reporting, would be that we could look at economics incentives through the IMF potentially. So we could consider having preparedness or risk reduction strategies as part of IMF assessments for countries. So I think that would help with poorer countries because they're quite attuned to that inflow of development assistance and capital. With regard to the World Health Organization, what can we do about that? I think it depends on how you understand international organizations. Do they do what states intend them to do? Are they just a puppet of states? Or do they have a mind of their own? And any recommendations that would come from that would depend on how you interpret the role and function of international organizations first. So I wouldn't say either way on the WHO, because I think it depends on how you interpret international organizations.
So it's kind of moving in the circle.
Yeah.
Well, I think there's a comment from Mona again. She's saying that she's just wondering, where do we position a risk-informed development paradigm in this discourse? A link with underlying causes deeply rooted in the current development approaches. And she gave an example of acute encephalitis syndrome in the state called Bihar in India. I don't know much about this acute encephalitis syndrome, AES, but Mona, would you like to speak a few words about it to explain it better?
Sure, thanks, Akhilesh. I'll keep it brief. So AES, the acute encephalitis syndrome, normally affects children year after year in a state called Bihar in India. There are other states also in India that do get affected. Typically, it affects children in in April, May, those kind of months when there is these are sweet berries, lychee crop that is harvested, and there are links to the existing conditions of undernourishment of children that prompts these poor children accompanying their mothers to harvest the crop, to consume raw lychees because of the severely high sugar content. There is some that leads to very high brain fever kind of conditions in children. Now this is almost like an epidemic year after year that peaks, and there are years where it's not that high, the incidence, but then that kind of a trend is seen now. And I took this example because this has very clear connections with the condition of nutrition of children in underdeveloped pockets in the country, such as the one that I'm citing. Some of these districts in the state of Bihar are very poor. So my point is that if we are looking at containing epidemics, not even containing, actually I'm talking of preparedness, the point that you started initially, then perhaps we may want to look at the underlying causes which are rooted in the development processes and approaches that are followed in countries so that we are stronger and we are less vulnerable to, these kind of hazards when we are confronted with them. That's the point I was trying to raise. Thank you.
Thank you, Mona. I absolutely agree with you. We can't look at this issue of health risk in isolation from any of the other cross-cutting factors that could be feeding into these kinds of occurrences. So there has been some recognition that health is a cross-cutting issue. Akhilesh would know more about this than I do, but they have started to bring health as a scorecard into the Resilient Cities Index. So that could be one starting point into your question of where do we position health and development in the discourse.
Yes. Thank you for acknowledging, Miranda. Appreciate that. And we can take it offline, if there's a further deep dive that we decide to do together. Yeah, I look forward to interacting with you and Akhilesh more on this. Thank you.
Thank you, Mona.
Thanks. I noticed that we have a gentleman, Jonathan, who joined all the way from Canada at the University of British Columbia. Jonathan, would you like to ask any question or make any comment? Let me check if you're still online. Or probably he left the session. That's all right. Anyone else who would like to ask a question or make any comment? Isaac, Penelope, Elimik, Goldrick, Ajib, Dave. I can see a few people from CDU, so they will certainly able to interact later, but I would like to ask questions, give this opportunity to those who are joining from different parts of the world, including different parts of Australia. We got about another 10 minutes or so to close the presentation.
Can I ask another question if nobody asks?
Okay, be brief. Thank you.
Yeah, so just to provoke the discussion here, because on the last point you touched on the possibility of including health dimension in urban resilience movement, and I believe after this there will be a big push to include health preparedness into disastrous management or disastrous reduction reports, like the GAR report, the Global Assessment Report for Disaster Reduction, that takes place every 2 years. But this is one of the problems. Once things like this happen, we try to integrate this new agenda into existing portfolios or into existing sectors. While we have been trying to also talk to help people to include disaster risk reduction into their agenda, but it's kind of hitting the hard wall as well. Everybody is kind of they want to get their agenda on board, but once we advocate our own agenda to their kind of sector, it's pretty hard for them to have as well. So this is a tricky point. How do we do that? Because certainly you can add as many as you can, because there are many important issues in the urban context. And health is not the only thing that is needed. I'm talking like this because if you look at the response at the moment from different countries, some countries, like in Australia, we try to use existing public health systems to respond to the coronavirus. But in certain countries, they don't use that kind of model. They use emergency management systems where health is included under that kind of framework to deal with the COVID-19 response. So this is, again, a tricky situation for me. So it's kind of a comment, or probably you can respond if you want. But this is just to fill up the time for something we can think about.
Thanks, Jonathan. Definitely something to think about. I believe there has been some efforts to integrate health with disaster risk reduction. So we have the emergence of the Health Emergency Disaster Risk Management Framework. My interpretation of that, it seems to be managing health risks that arise from hazard events, disaster events such as cyclones or tsunamis or earthquakes. But I think if I had the answer, I would probably, we'd probably get the Nobel Prize if we had the answers to some of those complicated questions you've been raising there.
This is to give you a perspective, like biodiversity colleagues have been trying to stand up and say something during this pandemic. But like if 10 months ago you asked anybody in the health system to consider, well guys, can you guys join us in the fight against biodiversity in the world? Will these people listen to us or not? I mean, that is kind of the thing that is probably very often mentioned as we have to deal with this like in a more integrated system, in a more like system approach. In the last 10 years, people have been trying to put on the agenda like One Health policy. Animals and human health is kind of putting together as one. And in order to do this, you have to engage heaps of players, including those who might be coming from, like ecology, biodiversity, environment, and so on. I feel that is pretty often not, it's quite distant from the health sector, traditionally speaking.
Thanks, Jonathan. There's a comment from Isaac. Miranda, are you able to see that?
Yeah, I think that's a fantastic suggestion from Isaac. Definitely, because we're in an anarchic environment. We can't force states to do this. We could use a carrot and stick approach, but we could also just, like Isaac said, develop an education program to demonstrate the returns on investment, definitely. I think that's an interesting comment from Mona there, and I don't know if Jonathan would like to comment on this as well. Punitive measures against states that are not containing epidemics. Well, quite a lot of states, in the case of Ebola, what we saw was states were overreacting, implementing more restrictive measures, and this fear caused quite a significant cost to the global economy, but also those affected states. What we saw, and this is just one example of COVID-19 in Indonesia, was that flights to Bali, the cost was reduced to encourage more tourism going into that area. So I don't know if Jonathan would like to pick up on that comment there.
Not so much, but I think I would like to think about what Mona asked about the punitive measures against states. I mean, this is pretty hard. The best way you could do is market punishment. That is probably more humane. So countries that are not following COVID prevention measures, I think their governments should actually suggest something that, like from the economic point of view, we have to kind of punish that kind of destination. But I'm not actually believing that using multilateralism to punish states. You could create certain disincentives, incentive mechanism around it, but it's pretty hard. It's a tricky one, how we design that. The one in Indonesia is this, as Bali, as Miranda mentioned, is actually a strange place at the moment. People still figuring out why the cases is so small, while the whole world is not believing that they have such a case that is so minimal at this point of time. The government is seen as not doing enough job to show, commitment in dealing with COVID. But how can we do that? I mean, how can we punish this kind of? Well, I think the best way you could do is thinking about educating your citizens on what are of the country, what are sort of countries or places that need to touch COVID-19. Apart from that, I have no idea. Still thinking.
I certainly would like to thank everyone for a fantastic presentation and joining from different parts of the world, including different parts of Australia. Thank you very much once again, and have a great day, and stay safe wherever you are. Bye-bye.
Thank you. Bye.